Hi, welcome to our channel of IGNOU Audiobooks. Indira Gandhi National Open University, School of Management Studies, SOMS, Certificate Programs. Certificate in NGO Management, CNM. BMS 003 Healthcare Management. Block-1 Primary Healthcare Management. Unit-1 National Health Policies. 1.1 Introduction. In this unit you will learn about various health-related policies. To begin with, you will learn about National Health Policy. You will learn about the genesis of National Health Policy 2000, its objectives and the thrust areas. Thereafter, you will learn about another important policy, i.e., National Population Policy, which was passed by the Parliament in 2000. You will learn about its objectives, strategic theories and various recommendations. Towards the end, you will learn about the National Nutrition Policy 1993. In this section, you will learn about the nutritional status of the country, the need for nutritional policy and its instruments, administration and monitoring. 1 point to National Health Policy, 2000. The World Health Assembly in 1997 in Geneva launched the ambitious goal of Health for All by 2000 AD. In the Alma-Ata Declaration in 1998 it was decided that primary health care would be the approach to achieve health for all. It was also suggested that every country should frame a health policy that should set some targets and a methodology to achieve them with the primary health care approach. India, since independence, had developed a well-organized public health infrastructure. National health programs were initiated in the country for major public health problems. These had all the four components of primary health care, viz., equitable distribution, intersectoral coordination, community participation, and appropriate technology. Nevertheless, in pursuance of the Alma-Ata Declaration, the Department 7 of Health, Ministry of Health and Family Welfare prepared a National Health Policy, NHP, duly approved by the Parliament in 1983. It had set definite targets which were to be achieved by 2000 AD. The NHP 1983 gave a general exposition of the policies which required recommendations in the circumstances then prevailing in the health sector. Some of the policy initiatives outlined yielded results, while in several other areas, the outcome has not been as expected. There have been marked changes in the determinant factors relating to the health sector since the formulation of the last policy, and hence the need for a revised NHP was felt, that resulted into NHP 2002. National Population Policy 2000, NPP 2000, was perceived as an offshoot of the NHP 1983 to give due importance of the management of the population problem of the country as securing the small family norm through voluntary efforts and moving towards the goal of population stabilization was emphasized in it. The International Conference on Population Development, ICPD, at Cairo in 1994 brought about a paradigm shift from the previous emphasis on demography and population control to sustainable development and recognition of the need for comprehensive reproductive health care and reproductive rights. The NPP 2000 reaffirmed India's commitment to ICPD principles and the program of action. A national health policy was last formulated in 1983, and since then government initiatives in the public health sector have recorded some noteworthy successes. However, the morbidity and mortality levels in the country are still unacceptably high. Malaria staged a resurgence in the 1980s. In TB, there has been no significant decline in the pool of infection among the community, and there has been an increase in drug resistance. HIV/AIDS has emerged as a public health problem. The common waterborne infections gastroenteritis, cholera, GD, some forms of hepatitis continue to contribute to a high level of morbidity. The period after the announcement of NHP 1983 has also seen an increase in mortality through the lifestyle diseases, diabetes, cancer, and cardiovascular diseases. The increase in life expectancy has increased the requirement for geriatric care. Another area of concern is the persistent incidence of macro and micronutrient deficiencies. The changed circumstances relating to the health sector of the country since 1983 have generated a situation in which it is now necessary to review the field and formulate a new policy framework. Objectives of National Health Policy. The main objective of this policy is to achieve an acceptable standard of good health amongst the general population of the country. The approach adopted would be to increase access to the decentralized public health system, ensure a more equitable access to health services, increase the aggregate public health investment, enhance the contribution of the private sector in providing health services, give primacy to preventive and first-line curative initiatives at the primary health level through increased sectoral share of allocation, lay emphasis on the rational use of drugs, increase access to the tried and tested systems of traditional medicine. Table 1.2 Goals to be achieved by 2000 to 2015. Eradicate polio and yaws 2005. Eliminate leprosy 2005. Eliminate Kala Azar 2010. Eliminate lymphatic filariasis 2015. Achieve zero-level growth of HIV/AIDS 2007. Reduce mortality by 50% on account of TB, malaria and other vector and waterborne diseases 2010. Reduce prevalence of blindness to 0.5% 2010. Reduce IMR to 31,000 and MMR to 100/lakh 2010. Increase utilization of public health facilities from current level of 20 to greater than 75% 2010. Establish an integrated system of surveillance, national health accounts, and health statistics. 2005. Increase health expenditure by government as a percent of GDP from the existing 0.9% 2010. Increase share of central grants to constitute at least 25% of total health spending 2010. Increase state sector health spending from 5.5% to 7% of the budget 2005. Further increase to 8% 2010. Current scenario and policy prescriptions. Financial resources. The central budgetary allocation for health over this period, as a percentage of the total central budget, has been stagnant at 1.3%, while that in the states has declined from 7.0% to 5.5%. The current annual per capita public health expenditure in the country is no more than Rs. 200. It is planned to increase health sector expenditure to 6% of GDP, with 2% of GDP being contributed as public health investment by the year 2010. The state government would increase the commitment of their resources to 7% and 8% of the budget by 2005 and 2010 respectively. Central government's contribution would rise to 25% from the existing 15% by 2010. 2. Equity. The attainment of health indices has been very uneven across the rural-urban divide. Access to and benefits from the public health system have been very uneven between the better endowed and the more vulnerable sections of society. This is particularly true for women, children, and the socially disadvantaged section of society. The NHP envisages an increased allocation of 55% of total public health investment for the primary health sector, 35% for the secondary, and 10% for the Tertiary health sector. 3. Delivery of national public health programs. The central government will design national programs with the active participation of the state governments. It will also provide financial resources, technical support, and monitor and evaluate the programs. Vertical programs for control of major diseases like TB, malaria, HIV/AIDS, RCH, and UIP would be integrated once moderate levels of prevalence are reached. 4. The state of public health infrastructure. Less than 20% of the population, which seek OPD services, and less than 45% of that which seek indoor treatment, avail of such services in public hospitals. The supply of drugs by the state governments is grossly inadequate. The policy envisages kickstarting the revival of the primary health system by providing some essential drugs. Need for levying reasonable user charges for those who can afford to pay is stressed. Extending public health services. There is a general shortage of medical personnel in the less developed and rural areas. The possibility needs to be examined of entrusting some limited public health functions to nurses, paramedics, and other personnel from the extended health sector, and imparting adequate training to them. State governments would consider the need for expanding the pool of medical practitioners to include a cadre of licentiates of medical practice, as also practitioners of LSMN. 6. Role of local self-government institutions. NHP 2002 lays great emphasis upon the implementation of public health programs through local self-government institutions. 7. Norms for health care personnel. Minimal statutory norms for the deployment of doctors and nurses in medical institutions need to be introduced urgently under the provisions of the Indian Medical Council Act and Indian Nursing Council Act, respectively. 8. Education of health care professionals. A medical grants commission for funding new government colleges is envisaged. Disciplines such as molecular biology and gene manipulation have become relevant since NHP 1983. 9. Need for specialists in public health and family medicine. Raising the proportion of postgraduate seats in these disciplines to 114th of the total seats is envisaged. Specialization in public health may be encouraged for non-medical graduates from the allied fields of public health engineering, microbiology and other natural sciences. Smiley nursing personnel. The policy lays emphasis on increasing the ratio of nursing personnel vis-a-vis doctors' beds, improving the skill level of nurses, and on increasing the ratio of degree-holding nurses vis-a-vis diploma-holding nurses. 11. Use of generic drugs and vaccines. This policy emphasizes the need for basing treatment regimens in both the public and private domain on a limited number of essential drugs of a generic nature, prohibiting the use of proprietary drugs, except in special circumstances, and encouraging the use of only essential drugs by the imposition of official disincentives. I-12. Urban health. The primary center is seen as the first tier, covering a population of 1 lakh, and a second tier of the urban health organization at the level of the government general hospital, where reference is made from the primary center. Fully equipped hub-spoke trauma care networks would be set up in large urban agglomerations. 13. Mental health. A network of decentralized mental health services and the upgrading of the physical infrastructure of mental health institutions is envisaged. 14. Information, education, and communication. The present IEC strategy relies too heavily on the mass media. Focus would be on the interpersonal communication and on folk and other traditional media to bring about behavioral change. The community leaders, particularly religious leaders, would be effectively utilized. School health programs would disseminate information relating to health and family life. 15. Health research. This policy envisages an increase in government-funded health research to a level of 1% of the total health spending by 2005, and thereafter, up to 2% by 2010. 16. Role of the private sector. The implementation of statutory regulation and the monitoring of minimum standards of diagnostic centers, medical institutions, along with 11 quality accreditation of clinical establishments, medical institutions becomes imperative. Setting up of a social health insurance scheme funded by the government and with service delivery through the private sector would be the appropriate solution. 17. The role of civil society. The government would encourage the handing over of public health service outlets at any level for management by NGOs and other institutions of civil society on an as-is-where-is basis along with the normative funds earmarked for such institutions. 18. National Disease Surveillance Network. The efficient disease surveillance network set up for polio and HIV/AIDS has demonstrated the enormous value of such a public health instrument. The full operationalization of an integrated disease control network from the lowest rung of public health administration to the central government by 2005 is envisaged. 19. Health statistics. The policy envisaged the completion of baseline estimates for the incidence of the common diseases TB, malaria, blindness by 2005 and for non-communicable diseases like CVD, cancer, diabetes, and accidental injury to S. and communicable diseases like hepatitis and J in a longer time frame. National health accounts, conforming to the source-to-users matrix structure, are to be established. XX. Women's health. NHP 2002 envisages the identification of specific programs targeted at women's health. 21. Medical ethics. Contemporary Code of Ethics is to be notified and rigorously implemented by the Medical Council of India. 22. Enforcement of quality standards for food and drugs. The Food and Drug Administration will be progressively strengthened in terms of both laboratory facilities and technical expertise. 23. Regulation of standards in paramedical disciplines. NHP 2002 recognizes the need to establish statutory professional councils for paramedical disciplines to register practitioners, maintain standards of training and monitor performance. XXIV. Environmental and occupational health. The independently stated policies and programs of the environment-related sectors be smoothly interfaced with the policies and the programs of the health sector. XXV. Providing medical facilities to users from overseas. The policy will assess the possibilities of encouraging the development of paid treatment packages for patients from overseas. XXVI. The impact of globalization on the health sector. The government will bring to bear its full influence in all international fora, UN, WHO, WTO, etc., to lighten the restrictive features of TRIPS in its application to the healthcare sector. XXVII. Intersectoral contribution to health. From the policy perspective, it is imperative that the independent policies of each of the interconnected sectors be in tandem, and that the interface between the policies of the two connected sectors be smooth. XXVII. Population growth and health standards. The synchronization of the NPP 2000 and NHP 2002 will be the cornerstone of any national structural plan to improve the health standards in the country. XXIX. Alternative systems of medicine. The policy features specific to the alternative systems of medicine will be presented as a separate document. 1.3 National Population Policy, 2000. The far-reaching consequences of growing population were realized as early as 1946 by the Bhore Committee. India after independence was the first country in the world to launch the family planning program in 1952. In 1976, before the Alma-Ata Conference, the country framed the Statement on National Population Policy, and in 1977 the Policy Statement on the Family Welfare Program. Both the statements were laid on the table of the House in Parliament but were never discussed and adopted. The National Health Policy of 1983 emphasized the need of achieving the small family norm, and while adopting it, the Parliament emphasized the need of a separate national population policy. The Karunkaran Committee on Population proposed in 1993 the formation of a national population policy. An expert group, headed by D.R. Swaminathan, prepared a draft national population policy in 1994, which was approved by the Cabinet in November 1997. It could not be placed before the Parliament due to the dissolution of the Lok Sabha. Another draft national population policy was placed before the Cabinet in March 1999. The Cabinet appointed a group of ministers who finalized a draft which was discussed in the Cabinet in November 1999. On the basis of the suggestions, a fresh draft was submitted which was finally approved as the National Population Policy. Objectives of the National Population Policy. Sharp decline in death rate after 1942 was not accompanied by concomitant fall in birth rate, and with the current trends India may overtake China in 2045. Stabilizing the population as an essential requirement for promoting sustainable development and equitable distribution is emphasized. Immediate objective of NPP 2000 is to address the unmet needs for contraception, healthcare infrastructure, and health personnel, and to provide integrated service delivery for basic reproductive and child health care. The medium-term objective is to bring the TFR to replacement levels by 2010 through vigorous implementation of intersectoral operational strategies. The long-term objective is to achieve a stable population by 2045 at a level consistent with the requirements of sustainable economic growth, social development, and environmental protection. National Socio-Demographic Goals for 2010. 1. Address the unmet needs for basic reproductive and child health services, supplies and infrastructure. 2. Make school education up to age 14 free and compulsory, and reduce dropouts at primary and secondary school levels to below 20% for both boys and girls. 1.3. Reduce infant mortality rate to below 30 per 1,000 live births. 1.4. Reduce maternal mortality ratio to below 100 per 100,000 live births. 5. Achieve universal immunization of children against all vaccine-preventable diseases. 6. Promote delayed marriage for girls, not earlier than age 18 and preferably after 20 years of age. 7. Achieve 80% institutional deliveries and 100% deliveries by trained persons. 8. Achieve universal access to information counseling and services for fertility, regulation and contraception with a wide basket of choices. 1.9. Achieve 100% registration of births, deaths, marriage and pregnancy. 1.10. Contain the spread of AIDS and promote greater integration between the 1. Management of RTLS and CENT-1 and the narco. 11. Prevent and control communicable diseases. 12. Integrate ISEM in the provision of RCH services and in reaching out to households. 13. Promote vigorously the small family norm to achieve replacement levels of TFR. 14. Bring about convergence in implementation of related social sector programs so that family welfare becomes a people-centered program. The population growth in India continues to be high on account of the large size of the population in the reproductive age group, 58%, and additional 417.2 million between 199 and 2016 is dissipated. There is a higher fertility due to the unmet need for contraception, estimated. Contribution 20%. Higher wanted fertility due to high IMR, estimated contribution 20%. Over 50% of the girls marry below the age of 18, resulting in a reproductive pattern of too early, too frequent, too many. A third of the births occur at intervals of less than 24 months, which also result in high IMR. Strategic themes: Decentralized planning and program implementation. Panchayati Raj institutions are an important means of furthering decentralized planning and program implementation in the context of the NPP 2000. However, in order to realize their potential, they need strengthening by further delegation of administrative and financial powers, including powers of resource mobilization. Further, since 33% of elected panchayat seats are reserved for women, representative committees of the panchayats, headed by an elected woman panchayat member, should be formed to promote a gender-sensitive, multisectoral agenda for population stabilization that will think, plan and act locally and support nationally. Neighborhood acceptor groups to be organized and provided with a revolving fund that may be accessed for income generation activities. The groups may establish rules of eligibility, interest rates, and accountability for which capital may be advanced, usually to be repaid in installments. Within 2 years, panchayats demonstrating exemplary performance will be nationally recognized and honored. 2. Convergence of service delivery at village levels. Efforts at population stabilization will be effective only if we direct an integrated package of essential services at village and household levels. Village self-help acceptor groups are to become the primary contact at household levels, providing fortnightly at one place 6 different services for registration of births, deaths, marriage and pregnancy. 2. Weighing of children under 5 years and recording the weight on a standard growth chart. 3. Counseling and advocacy for contraception. Free supply of contraceptives. 4. Preventive care, with availability of basic medicines for common ailments, nutrition supplements, and 6. Advocacy and encouragement for the continued enrollment of children in school up to age 14. We need to promote a more flexible approach by extending basic reproductive and child health care through mobile clinics and counseling services for remote inaccessible or sparsely populated regions. An equipped maternity hut in each village should be set up to serve as a delivery room. At village levels, the Anganwadi center may become the pivot of basic health care activities, contraceptive counseling and supply, nutrition education and supplementation, as well as preschool activities. The Anganwadi centers can also function as depots for ORS medicines and contraceptives. Meaningful decentralization will result only if the convergence of the National Family Welfare Program with the ICDS program is strengthened. Trained birth attendants, as well as the vast pool of traditional days, should be made familiar with emergency and referral procedures. Provide a wider basket of choices in contraception through innovative social marketing schemes to reach household levels. 3. Empowering women for improved health and nutrition. Provide cluster services for women and children at the same place and time and open more child care centers in rural areas and urban slums. Facilitate access to fuel wood, fodder and potable water. Strengthen emergency obstetric and neonatal care at various levels along with strengthening of referral services and transportation. Maternal and prenatal audit. Deployment of community midwives and additional health providers at village. Monitor performance of MCH services at each level. Improve technical skills of MCH care providers. Develop a health package for adolescents. Expand the availability of safe abortion care. Develop maternity hospitals at sub-district levels and at CHCs to function as FRUs. Formulate and enforce standards for clinical services in the public, private, and NGO sectors. 4. Child health and survival. Infant mortality is a sensitive indicator of human development. Infant mortality rates have not significantly declined in recent years. Intensifying neonatal care is a priority, and a national technical committee should be set up. The Baby-Friendly Hospital Initiative, BFHI, should be extended to all hospitals and clinics up to subcenter levels. The BFHI should include updating of skills of trained birth attendants too. Improve newborn care practices to reduce the risks of hypothermia and infection. Essential equipment for the newborn must be provided at subcenter levels. Pursue compulsory registration of births in coordination with the ICDS program. Train health personnel in the integrated management of childhood illnesses. Encourage voluntary groups as well as NGOs to formulate and implement special schemes for street children and child laborers. Explore the feasibility of a national health insurance covering hospitalization costs for children below 5 years whose parents have adopted the small family norm and opted for a terminal method of contraception after the birth of the second child. Expand the LCDS to include children between 6 to 9 years of age, specifically to promote and ensure 100% school enrollment, particularly for girls. Promote primary education with the help of Anganwadi workers and encourage retention in school till age 14. Education promotes awareness, late marriages, small family size and higher child survival rates. Provide vocational training for girls. Meeting the unmet needs for family welfare services. The different unmet needs need to be addressed on priority, in particular, an increase in rural infrastructure, deployment of sanctioned and appropriately trained health personnel, and provisioning of essential equipment and drugs. Formulate and implement innovative social marketing schemes to provide subsidized products and services. Improve facilities for referral transportation at Panchayat, Zilla Parishad and primary health center levels. At subcenters, provide ANMs with soft loans for purchase of mopeds to enhance their mobility. Encourage local entrepreneurs at village and block levels to start ambulance services and chemist shops through special loan schemes with appropriate vehicles to facilitate transportation of persons requiring emergency as well as essential medical attention. 6. Underserved population groups. A. Urban slum. Nearly 100 million people live in urban slums with little or no access to potable water, sanitation facilities, and health care services. Basic and primary health care, including RCH care, needs to be provided. Coordination with municipal bodies for water, sanitation, and waste disposal must be pursued, and targeted IEC campaigns must spread awareness about the secondary and tertiary facilities available. B. Tribal communities, Hill area populations and displaced and migrant are populations. Tribal populations often have high levels of morbidity arising from poor nutrition, particularly in situations where they are involuntarily displaced or resettled. Frequently, they have low levels of literacy, coupled with high infant, child, and maternal mortality. These communities need special attention in terms of basic health and RCH services. NGOs should be encouraged to provide health care that will be responsive to seasonal variations in the availability of work and income. Information and counseling on infertility may be needed. C. Adolescents. Adolescents represent about a fifth of India's population. Reproductive health services for adolescent girls and boys are especially significant in rural India, where adolescent marriage and pregnancy are widely prevalent. Provide for adolescents the package of nutritional services available under ICDS. Enforce the Child Marriage Restraint Act, 1976. D. Increased participation of men in Planned Parenthood. The active involvement of men is called for in planning families, supporting contraceptive use, helping pregnant women stay healthy, arranging skilled care during delivery, avoiding delays in seeking care, helping after the baby is born, and finally, in being a responsible father. Further, currently, over 97% of sterilizations are tubectomies, and this manifestation of gender imbalance need to be corrected. The special needs of men include repopularizing vasectomies, in particular no scalpel vasectomy as a safe and simple procedure, and focusing on men in the information and education campaigns to promote the small family norm. 7. Diverse health care providers. Explore the possibility of accrediting the private practitioners for a year at a time and assign to each a satellite population, not exceeding 5,000, depending upon distances and spread, for whom they may provide RCH services. Revive the earlier system of the licensed medical practitioners. Involve the non-medical fraternity in counseling and advocacy so a 3-2. Demystify the national family welfare effort, modify the under postgraduate medical, nursing, and paramedical professional course syllabi and curricula, in order to reflect the concepts and implementation strategies of the RCH program and NPP. Ensure the efficient functioning of the first referral units, i.e., 30-bed hospitals at block levels. Augment the availability of specialists in the disciplines of gyno, anesthesia, and pediatrics by increasing seats in medical institutions and simultaneously through the National Board of Medical Examination and open universities like IGNOU in larger numbers. 8. Collaboration with and commitments from non-government organizations and the private sector. We need to put in place a partnership of non-government voluntary organizations, the private corporate sector, government, and the community. Private health accounts for nearly 75% of healthcare expenditure. Collaboration between the voluntary sector and the NGOs will facilitate dissemination of efficient service delivery to village levels. Encourage the voluntary sector to motivate village-level self-help groups to participate in community activities. Provide markets to sustain the income-generating activities from village level upwards. 8. Collaboration with and commitments from non-government organizations and the private sector. We need to put in place a partnership of non-government voluntary organizations, the private corporate sector, government, and the community. Private health accounts for nearly 75% of healthcare expenditure. Collaboration between the voluntary sector and the NGOs will facilitate dissemination of efficient service delivery to village levels. Encourage the voluntary sector to Motivate village-level self-help groups to participate in community activities. Provide markets to sustain the income-generating activities from village level upward. 9. Mainstreaming Indian systems of medicine and homeopathy. Utilization of IGNOU in basic RCH care will expand the pool of effective health care providers, optimize utilization of locally based remedies and cures, and promote low-cost health care. At village level, the services of the IGNOU barefoot doctors, after appropriate training, may be utilized for advocacy and counseling, for distributing supplies and equipment, and as depot holders. KISS Smiley contraceptive technology and research on reproductive and child. Government must constantly advance, encourage, and support medical, social science, demographic and behavioral science research on maternal, child and reproductive health care issues. This will improve medical techniques relevant to the country's needs and strengthen program and project design and implementation. 11. Providing for the older population. Improved life expectancy is leading to an increase in the absolute number and proportion of persons aged 60 years and above, and is anticipated to nearly double during 1996 to 2016, from 62.3 million to 112.9 million. When viewed in the context of significant weakening of traditional support systems, the elderly are increasingly vulnerable, needing protection and care. Promoting old age health care and support will, over time, also serve to reduce the incentive to have large families. Recommendations. In order to enable state governments to fearlessly and effectively pursue the agenda for population stabilization contained in the NPP 2000, it is recommended that the number of seats to the Lok Sabha and the Rajya Sabha be frozen till 2001 based on the 197 census be extended up to 2026. Public support. Demonstration of strong support to the small family norm as well as personal. Example, by political, community, business, professional and religious leaders. Media and film stars, sports personalities, and opinion makers will enhance its acceptance throughout society. The government will actively enlist their support in concrete ways. New structures. The NPP 2000 is to be largely implemented and managed at Panchayat and Nagar Palika levels, in coordination with the concerned state union territory administrations. This would require multisectoral coordination of planning and implementation between health and family welfare and schemes for education, nutrition, women and child development, safe drinking water, sanitation, rural roads, communications, transportation, housing, forestry, development, environmental protection, and urban development. Accordingly, the following structures are recommended. I. National Commission on Population. A national co-nation o population, presided over by the Prime Minister, will oversee and review the implementation of policy. The Commission Secretariat will be provided by the Department of Family Welfare. 2. Stati Commissions on Population. Each state and UT may consider having a state ICTT Commission on Population, presided over by the Chief Minister, on the analogy of the National Commission, to likewise oversee and review implementation of the NPP 2000 in the state UT. 3. Coordination Cell in the Planning Commission. The Planning Commission will have a coordination cell for intersectoral coordination between ministries for enhancing performance, particularly in states needing special attention on account of adverse demographic and human development indicators. 4. Technology Mission in the Department of Family Welfare. To enhance performance, particularly in states with currently below average sociodemographic indices that need focused attention. A technology mission in the Department of Family Welfare will be established. Funding. Priority in allocation of funds will be given to improving healthcare infrastructure at the community and primary health centers, subcenters, and village levels. Critical gaps in manpower will be remedied through redeployment, particularly in underserved and inaccessible areas, and referral linkages will be improved. In order to implement immediately the action plan, it would be necessary to double the annual budget of the Department of Family Welfare to enable government to address the shortfall in unmet needs for healthcare infrastructure, services and supplies. Promotional and motivational measures for adoption of the small family norm. The following promotional and motivational measures will be undertaken. Panchayats and Zilla Parishads will be rewarded and honored for exemplary performance in universalizing the small family norm, achieving reductions in infant mortality and birth rates, and promoting literacy with completion of primary schooling. 2. The Beka Samriddhi Yojana run by the Department of Women and Child Development to promote survival and care of the girl child will continue. A cash incentive of Rs. 500 is awarded at the birth of the girl child of birth Order 1 or 2. 3. Maternity benefit scheme run by the Department of Rural Development will continue. A cash incentive of Rs. 500 is awarded to mothers who have their first child after 19 years of age, for birth of the first or second child only. Disbursement of the cash award will in future be linked to compliance with antenatal checkup, institutional delivery by trained birth attendant, registration of birth, and BCG immunization. 4. A family welfare-linked health insurance plan will be established. Couples below the poverty line who undergo sterilization with not more than 2 living children would become eligible, along with children, for health insurance for hospitalization not exceeding Rs. 5,000 and a personal accident insurance cover for the spouse undergoing sterilization. Colonel tilde place below the poverty line who marry after the legal age of marriage. Register the T tilde tilde arrayage, have date fits child after the mother reaches the age of 21, accept the small family norm and adopt a terminal method after the birth of the second child, will be rewarded. 6. A revolving field will be set up for income-generating activities by village level. Self-help groups who provide community-level health care services. 7. Creches and child care centers will be opened in rural areas and urban slums. This will facilitate and promote participation of women in paid employment. 8. A wider, affordable choice of contraceptives will be made accessible at diverse delivery points with counseling services to enable acceptors to exercise voluntary and informed consent. 9. Facilities for safe abortion will be strengthened and expanded. 10. Products and services will be made affordable through innovative social marketing schemes. 11. Local entrepreneurs at village levels will be provided Soft 1 OA 11S and encouraged to run ambulance services to supplement the existing arrangements for referral transportation. 12. Increased vocational training schemes for girls, leading to self-employment, will be encouraged. 13. Strict enforcement of Child Marriage Restraint Act, 1976. 14. Strict enforcement of the Prenatal Diagnostic Techniques Act, 1994. 15. Soft loans to ensure mobility of the ANMs will be increased. 16. The 42nd Constitutional Amendment has frozen the number of representatives in the Lok Sabha on the basis of population at 197.1 census levels. The freeze is currently valid until 201, and has served as an incentive for state governments to fearlessly pursue the agenda for population stabilization. This freeze needs to be extended until 2026. 1.4 National Nutrition Policy, 1993. Widespread poverty resulting in chronic and resistant hunger is the single biggest scourge of developing world today. Undernutrition reduces work capacity and productivity among adults and increases mortality and morbidity among children. Such reduced productivity translates into reduced earning capacity, leading to further poverty, and the vicious circle of poverty goes on. Need for a nutrition policy within the development context. Post-independence India has a proud record of achievement in food production. From being a deficit nation, depending on food imports in the 60s, to having become surplus in food grains in the 80s, is a saga of concerted agricultural research, extension work and development, resulting in a dramatic productivity increase. And yet, endemic malnutrition and ill health resulting from malnutrition continue to stalk the country. It is this stark reality that underscores the need for a nutrition policy. Increased food production by itself does not necessarily ensure nutrition for all. Only economic development or even the adequacy of food at household levels are no guarantees for a stable and satisfactory nutritional status. Nutrition has to be tackled independently, along with other development issues. This is not all the time. Dimension is also important. Both short as well as long-term strategies are called for, comprising both direct as well as indirect intervention. The nutritional status of LNDA. There has been a steady increase in aggregate consumption of calories at household level. However, there has not been a commensurate increase in consumption of proteins and preemptive foods like fats and oils. The major nutrition problems of LNDA can be classified as follows. 1. Undernutrition result in A. Protein energy malnutrition, PEM. B. Iron deficiency. C. Iodine deficiency. D. Vitamin A deficiency. E. Low birth weight children. 2. Seasonal dimensions of nutrition. 3. Natural calamities and the landless. 4. Market distortion and disinformation. 5. Urbanization. 6. Special nutritional problems of the hill people, industrial workers, migrant workers and other special categories. 7. Problems of overnutrition, overweight and obesity for a small section of the urban population. 1. Undernutrition. A. Protein energy malnutrition. It is the most widespread form of malnutrition among preschool children in our country, with 43.8% suffering from moderate and 8.7% suffering from severe malnutrition. Urban slums has the lowest proportion of children with normal body weight and the highest proportion of severely malnourished children. B. Iron deficiency anemia. It has been estimated that 56% preschool children and almost 50% of the expectant mothers in the third trimester of pregnancy suffer from iron deficiency. Low iron intake coupled with hookworm infestation and infections further aggravates the problem. C. Iodine deficiency disorder. Nearly 40 million persons are estimated to be suffering from goiter, and 245 million are living in the known goiter endemic regions. 2.2 million children are affected with cretinism, 6.6 million are mildly retarded. Iodine deficiency also accounts for 90,000 stillbirths and neonatal deaths every year. D. Vitamin A deficiency. Nutritional blindness affects over 7 million children, with 60,000 children becoming blind every year. According to NNMB 1990, in none of the states was the average intake comparable to the recommended level. Prevalence of low birth weight children. In India, 30% of all the infants born are low birth weight babies. Weight less than 2,500 grams. Low birth weight was found to be connected with several factors such as age of the mother, maternal weight gain during pregnancy, interpregnancy interval, hemoglobin less than 8 g/m%, and maternal literacy. National Health Policy has set a goal of bringing down the incidence of low birth weight by 10% by 2000 AD and the maternal mortality rate to 2 per 1,000 live births by 2000. 2. Seasonal dimensions. Seasonality of employment and availability of food at household level results in women and children falling below the survival line during lean periods. 3. Natural calamities and nutrition. The worst affected groups are the landless, agricultural laborers, artisans, craftsmen, and non-agricultural laborers in that order. 4. Market distortion and disinformation. It is not any substantial food shortage but the psychology of food shortage and the widespread belief regarding crop failure that triggers of price rise spirals resulting in major malnutrition situations. 5. Urbanization. Nutritional status of urban slum dwellers in India is almost as bad as that of the rural poor. The fallout of a spreading urban culture, encouraging diversion of a high proportion of family expenditure to luxury goods and entertainment aggravates the situation. Nutrition policy instruments. Strategy for development, comprising a frontal attack on poverty, unemployment, and malnutrition, became a national priority in the WE plan from the earlier emphasis on percolating efforts of growth. Nutrition affects development as much as development affects nutrition. The problem of nutrition should be tackled through direct nutrition intervention for specially vulnerable groups as well as through development of policy instruments which will create condition for improved nutrition. 1. Direct intervention short term. Nutrition intervention for specially vulnerable groups. Expanding safety net. While more children are surviving today, an overwhelming large number of them are destined to remain much below their genetic potential. There is, therefore, an immediate imperative to substantially expand the nutrition intervention net through ICDS so as to cover all vulnerable children in the age group 0 to 6 years. B. Reducing malnutrition, with the objective of reducing the incidence of severe and moderate malnutrition by half by the year 2000 AD. A concerted effort needs to be made to trigger appropriate behavioral changes among the mothers. Improving growth. Monitoring between the age group 0 to 3 years, in particular, with the closer involvement of the mothers, is a key intervention. C. Reaching the adolescent Gillis, the nutritional status of adolescent girls should be improved and they be given some skill upgradation. Training in home-based skills. They should be covered by non-formal education, particularly nutrition and health education and nutrition. D. Ensuring better coverage of expectant mothers, supplementary nutrition right from the first trimester continuing during the major period of lactation should be done to reduce the incidence of low birth weight. 2. Fortification of essential foods. Essential food items shall be fortified with appropriate nutrients, e.g., salt, with iodine and or iron. Research in fortification of rice and other cereals should be intensified. 3. Popularization of low-cost nutritious food. Low-cost nutritious foods from indigenous and locally available raw material shall be popularized. 4. Control of micronutrient deficiencies amongst vulnerable groups. Deficiencies of vitamin A, iron and folic acid and iodine among children. Pregnant women and nursing mothers shall be controlled and anemia in expectant mothers reduced to 25% by 2000 AD. Iron supplementation 2. Adolescent girls shall be introduced. Nutritional blindness should be completely eradicated by the year 2000. 2. Indirect policy instruments long-term institutional and structural changes. Food security. In order to ensure aggregate food security as per capita availability of 215 kg per year of food grains needs to be attained, which will require attaining 230 million tons food grains production by 2000 AD. 2. Improvement of dietary pattern tells rock production and demonstration. The production of pulses, oilseeds and protective food crops such as vegetables, fruits, milk, meat, fish and poultry shall be augmented. Our agricultural policy has hitherto been concerned with production exclusively and not with nutrition. Coarse grains and pulses, which constitute the poor man's staple and protein requirements, have not received adequate attention. The prices of pulses, which were below cereal prices before the Green Revolution, are now almost double the price of cereals. Our food policy should be consistent with our national needs. 3. Policies for effecting income transfer. The policies for effecting income transfer to improve the entitlement package of the rural and urban poor are: A. Improving the purchasing power, poverty alleviation programs like the Integrated Rural Development Program, IRDP, and employment generation schemes like the Jawahar Rozgar Yojana and DWCRA are to be reoriented and restructured to make a forceful dent on the purchasing power of the lowest economic segments of the population. B. Public distribution systems, ensuring an equitable food distribution. Through the expansion of the public distribution system, particularly those living below the poverty line, not only in urban areas but throughout the country. The public distribution system should be strengthened, especially during the monsoon months, for giving special rations at specially subsidized rates for at least 4 months, July to October, to the seasonally at-risk population. 4. Land reforms. Tenural reforms as well as implementation of sealing laws will be held Artel Family Welfare. Clyroid Health for All by 2000 AD program, increased health and immunization facilities shall be provided to all. Schnall family norm and adequate spacing shall be encouraged. 6. BR-sick health CMRL and nutrition knowledge. Nutrition and health education concepts shall be effectively integrated into the school curricula as well as into nutrition programs. 7. CV quart of food A. 1 nutrition. Enforcement machinery needs to be geared up. 8. Nutrition surveillance. The NNMB should assist the impact of ongoing nutrition and development programs and serve as an early warning system to initiate prompt action. 9. Monitoring QF nutrition programs. Monitoring of nutrition programs, WIS, ICDS, and of nutrition education and demonstration by the Food and Nutrition Board through all its 67 field centers and units should be continued. 10. Research. Research into various aspects of nutrition, both 011 the consumption side as well as the supply side, is another essential aspect of this strategy. 11. Equal remuneration. The wages of women should be at par with that of men in order to improve Women's economic status. This requires a stricter enforcement of the Equal Remuneration Act. 12. Communication. Communication through established media is one of the most important strategies to be adopted for the effective implementation of the nutrition policy. Not only the electronic media but also folk and print media should be used extensively. The media policy shall focus on ways and means to combat malnutrition among girl children, adolescent girls, and women in the reproductive age group. 13. Minimum wage administration. There is a need to ensure an effective minimum wage administration and timely revision, linking it with the price rise. Legislation should be introduced for providing agricultural women laborers the minimum support and at least
XIV, community participation. The active involvement of the community is essential not only in terms of being aware of the services available to the community but also for deriving the maximum benefit from such services by giving timely feedback necessary at all levels. 15. Education and literacy, particularly that of women, is a key determinant for better nutritional status. XVI, Insprovenzers of TLFE status QF Women's EMP4 ointment benefits household nutrition, both leroyly increase in household income as well as increase in women's status, autonomy and decision-making power. Administration and monitoring. 1. Implementation of NNPA. There should be a close collaboration between the food policy, agriculture policy, health policy, education policy, rural development and program and the nutrition policy as each complements the other. B. An interministerial coordination committee will function in the Ministry of Human Resource Development under the chairmanship of the Secretary, Department of Women and Child Development, to oversee and review the implementation of nutrition intervention measures. C. A National Nutrition Council will be constituted in the Planning Commission with the Prime Minister as President for overseeing the implementation of the NNP through the various plans of action and will issue policy guidelines based on the latest nutritional surveillance feedback. 2. Monitoring of nutrition situation. Nutritional surveillance of the country's population, especially children and mothers, shall be the responsibility of the National Institute of Nutrition, NNMB. 3. Role of the state governments. The cutting edge of the governmental interventions commences from the state level. There should be an apex state-level nutrition council to be chaired by the Chief Minister and would focus on the state-level targets for the various nutrition-related indicators-based targets set under the NNP. 4. Mobilization of resources. It is necessary to mobilize resources from within the community in order to ensure sustainability of these interventions. State governments have started a major midday meal program funded out of state resources. The other state governments, UTs, may also consider such an introduction in their primary and secondary schools. After the NNP of India is operationalized, with the specific objectives, plans of action, strategies, targets and time frame, development of state-level policies shall be encouraged. Intervention programs to combat malnutrition. 1. Integrated Child Development Services. 2. Special Nutrition Program. 3. Balwadi Nutrition Program. 4. Wheat-Based Supplementary Nutrition Program. 5. Tamil Nadu Integrated Nutrition Program. 6. Midday Meal Program. 7. Nutritional Anemia Prophylaxis Program. 8. Prophylaxis Program Against Blindness Due to Vitamin A Deficiency. 9. Goiter Control Program. 10. National Diarrhea Diseases Control Program. 1.5 Summary. This unit covers NHP 2002, NPP 2000, and NNP 1993. The original policy documents are lengthy and hence have been discussed in a summary form in this unit, highlighting the important components. NHP 201 document is divided into 5 sections. A. Introduction, dealing with the achievements from 195-1 to 2000. The current disease burden and the need for NEIP 2002. B. Current scenario, divided into 29 subheads. C. Objectives and the goals to be achieved by 201-5. D. Policy prescriptions that describe what should be done regarding the first 26 subheads of the current scenario. and E. Summation. These 5 sections have been clubbed to 2 subsections in this unit. NPP 2000 is divided into 9 subheads. A. Introduction. B. Objectives, including national demographic goals for 210. C. 12 strategic themes. D. Legislation. A. Public support. F. New structures like national and state commissions on population, a coordination cell in the planning commission and a technology mission. 8. Action plan for the strategic themes is described. 11. Milestones in the evolution of the population policy of India. I. Demographic profile and the unmet needs and deficiency in contraceptive services. The nodal agency of NNP 1993 is the Department for Women and Child Development, Ministry of HRD. NPP is divided into 6 subheads. A. Introduction that deals with the vicious cycle or poverty. B. Need for a nutrition policy. C. Nutritional status of India. D. Existing policy instruments for combating malnutrition. A. Nutrition policy instruments. And F. Administration and monitoring. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.